Why don't we get started with the next session? My name is Joe Hines. I'm a surgeon here at UCLA. And I wanted to start the session. I thought the last two talks from Dr. Saluja and Chari were really wonderful. A lot of interest in how those studies might affect patients who are in the room. Family members are interested about how this new information may impact the treatment of patients that currently have pancreatic cancer. And I just want to put a cautionary line in. We don't want people to leave today and start asking their doctors to prescribe antibiotics to treat their tumors. I mean, I hope everybody understands that. So a lot of the work that's done in the mouse models and the preclinical work really requires a lot more work to make sure that these types of approaches, although very exciting, will make sense for our patients in the clinics. I'm going to start this next session, which is on personalized medicine tumor testing, and introduce the main speaker of the session here in just a second. We've noticed we have a large multidisciplinary group that deals with pancreatic diseases at UCLA under the umbrella of the UCLA Agi Hirshberg Center for Pancreatic Diseases. We meet every Tuesday and discuss patients who are coming to see us that day in the afternoon. We talk about what we think the best treatment plan will be. We have follow-up patients come to talk to us and make plans for their treatments for whatever condition that ails them regarding their pancreas. And we've noted that really over the last 12 to 18 months, that part of our discussion for the first time is really talking about specific markers of the tumor, genetics of the tumor, of the patient, and how that might inform our decisions about treatment for the patient. So this is something very new. Lots of folks have hoped that this would come. I think we're at the very beginning of this phase, but it's pretty exciting because we have some now options available based on the genetic analysis, not only of the tumor, but also of the patient themselves. This past year, a really important event occurred. The National Comprehensive Cancer Network revised their treatment guidelines for patients with pancreatic cancer and have advised that all patients with a diagnosis of pancreatic cancer should undergo genetic testing. And why is that? Well, over the past years, there's been a lot of accumulation of information from various studies that would suggest that genetics are important for pancreatic cancer, and we've kind of come to a bit of a tipping point. In this journal article in JAMA this past year, looking at some 3,000 patients with pancreatic cancer and over 120,000 patients who don't have disease, or what we call normal controls, found that there were 6 genes that were particularly of interest that increase the chance of pancreatic cancer and have implications for family members. And so we're going to spend the next hour or so talking about that. We're very lucky. You'll get to hear from Wendy in a little bit about her work. She really tells us what's happening in this area in our conferences and really been a great addition to the group. I want to introduce Dr. Tim Donahue. Dr. Donahue is going to take us through this session. He is a professor of surgery. He's the chief of the Division of Surgical Oncology and vice chair for surgical cancer care in the Department of Surgery. He's also in charge of the residency training program and has a really important role in the Cancer Center for Pancreatic Cancer and is really driving a lot of the major parts of our program and doing cutting-edge research that I think is highly translational. He's going to take us through this concept of personalized medicine for patients with pancreatic cancer. Dr. Donahue.
Thank you, Dr. Hines. I have another slide set. There it is. Okay, so I'm tasked with, been asked to talk about personalized medicine and tumor testing for pancreatic cancer. I'm going to go through a set of slides here, and I assume there's going to be a number of questions. And I've asked Dr. Randy Hecht, one of our GI medical oncologists who works a lot with pancreatic cancer patients, to come up and help answer the questions, as I'm sure he's much more credentialed to do this. I just wanted to first say that there's a new initiative that's going on across the University of California's, and we're forming a collaborative or a consortium to all work together. This is efforts by the University of California Office of the President, Janet Napolitano, and so the UCSF, UC Davis, UC LA, UC San Diego, and UC Irvine. We've gotten together twice already to start discussing how we can all work together and bond together and combine all of our resources to answer important questions for this disease. We're next meeting here at UCLA on June 7th. This is the cancer registry data from each of the UCs. And I just am so proud to show that we have such a great program, the UCLA Agi Hirshberg Center for Pancreatic Diseases, and are the largest of all the UCs in terms of volume of patients seen, number of patients seen, and treated with pancreatic cancer. Okay, so we're going to talk about genomic testing, personalized medicine for targeted therapies for tumors. And this is a cartoon, but the basic concept is to look at tumors after they're removed or biopsied, test them for various mutations, and then try and match up therapies or treatments that target those changes that are present within tumors. The different things within the tumor that can be tested are the DNA in the tumor cells, which then is transcribed into RNA, which also can be tested, which is then translated into proteins, which also can be tested. But the most common thing that are tested are usually the DNA, where sequencing efforts are looking for mutations that are present within tumors, and also staining, immunohistochemistry, to look and see if there's protein expression and or loss. So in terms of testing tumors or profiling tumors, the most common things that's done are DNA and protein. The one other concept I wanted to tell you about is Wendy Conlin, our genetic counselor, who sees many of our patients, is going to talk after me, and she's going to talk about germline testing, right? So there are two different types of mutations that can occur. There's germline mutations that you have in all cells of your body, and then there are somatic mutations or additional mutations that can form just in the tumor cells themselves, which can lead to tumor development and or progression. And what I'm going to talk mainly about is exclusively about is tumor testing, or those somatic mutations, and we'll focus on DNA sequencing for tumors, less on the protein analysis. So we just started, this was the first sequencing analysis of pancreatic cancer that came out in 2008. This is where it all started. Not so long ago was when the first tumors were really sequenced by Bert Vogelstein and Ken Kinsler. This was, as I said, in 2000. It was a major effort, right? A major effort that found 12 core signaling pathways and mutations that were altered in pancreatic cancer tumors, and this landed them a paper in Science, right? So the first effort. But now we've come a long way just in the last 10 years or so, where tumor sequencing or DNA sequencing of tumors has become somewhat commonplace for treatment or identifying what are thought to be the most effective treatments for patients. The most common companies that are used, that we use, are Foundation Medicine, which you may have heard of, and Perthera, to profile or sequence patients' tumors. We're not doing it in-house just yet. So this is a schematic of the genetic landscape of pancreatic cancer, and what's listed there on the left are the most frequent genes that have mutations within these tumors. They have different alterations associated with them, and then the hash marks on each gene are a tumor in this set where there's an alteration in that gene. And you can see at the top there's a lot of hashes, there's a lot of greens or bars in each of the genes, and KRAS and P53 and P16 and SMAD4, which are some genes. But as it goes down, they're not that frequent, and there are not that many frequent alterations. So, it's thought that this tumor has some core genetic alterations, but then a smattering of other genetic alterations. This is, I think they're called word salads or letter salads or something like that, where you can see it depicts all the different mutations that are present within pancreas tumors. And the most prominent one that's there is KRAS, and as I said, P16, P53, and SMAD4. And the problem with each of these is that they have not been targetable, right? I say have not because I'll show a slide in just a second where it's thought that KRAS is thought to start to be targetable. But to date, KRAS really hasn't been targetable, which is kind of the driver oncogenic mutation in pancreas cancers. And it's been felt that if a KRAS inhibitor could be developed, perhaps that may be the magic bullet to at least start developing some combination therapies that are going to get to this tumor. There's been a ton of money poured into trying to develop a KRAS inhibitor, which would, apply to probably potentially all patients in this room. The NCI has actually started a RAS initiative because KRAS is one of the most frequently altered mutations in all cancers, particularly in pancreatic cancer. Here's an application of tumor genetic profiling that was published by the Pancreatic Cancer Action Network, where they looked at 640 patients in this series. It was a retrospective series. And in this paper that they published, they reported that they found genetic alterations in 50% of patients. 27% were so-called highly actionable, right? So ones that they felt were either directly targetable or that would predispose the patients to responding to therapies that took advantage of the vulnerabilities that were associated with the mutations that were there. These are some of the processes that were involved: DNA repair, the chemotherapies or targeted therapies that damage DNA. These patients had altered DNA repair mechanisms, cell cycle changes. Anyways, they also found in this study that patients who were treated with matched drugs had significantly better survival than patients who were given unmatched drugs to the mutations that were present within these tumors. Forms the basis or the rationale for a campaign that they have now called Precision Promise, where they're trying to match the genetic profile of tumors to patients' treatments. I talked about KRAS, right? So KRAS, I'm sure many of you, all of you have heard about KRAS, the driver oncogene in pancreatic cancer. The most mutations in the RAS oncogene in pancreas cancer occur in this one area. So there's a one codon, or 3 DNA bases that are substituted that makes this protein hyperactive, or extremely highly active, and you can't shut it off. So it just keeps providing this signal for tumor proliferation, growth that will not shut off. As I told you, we're just starting to figure out how to inhibit this protein and drugs that may be able to target it. And the one specific KRAS mutation that can be targeted now is what's called the G12C mutation. Unfortunately, it only occurs in about 2.5% of patients with pancreatic cancer. There's a number of companies here that I've listed: Wellspring, Cura, Mirati, Amgen, that are all developing KRAS G12C inhibitors. It's more common in lung cancer, but again, it does occur in pancreas cancer. We're very interested in working with one of these companies on a clinical trial to apply this to our pancreas cancer patients. Also, Will Go here from A2 Biotherapeutics is working on developing CAR T cells for KRAS for pancreas cancer patients. And so we're also hoping to work and planning to work with him on cell-based therapy to target KRAS. So KRAS is starting to become potentially targetable, both with therapeutics and or cell-based therapies, but we have a long way to go. A concept you may have heard about, which I think was referred to earlier in terms of microsatellites, instability. I want to introduce this concept and show you how it can apply to targeted therapies or immunotherapies for patients. Microsatellite instabilities are mutations in your DNA. So patients who have high microsatellite instability have defects or alterations in the proteins that are necessary to repair DNA, and as a result of losing those, they have multiple satellites of mutations interspersed throughout their DNA. And so this microsatellite instability, because you've got mutations all throughout your DNA, it leads to mutant proteins that the immune system sees as foreign, right? So the immune system doesn't recognize these mutant proteins. And the microsatellite instability, it can be tested either with immunohistochemistry for proteins or DNA to look for mutations. Microsatellite instability or loss of these repair proteins occurs in 1 to 2% of pancreas cancer patients. And these tumors are more responsive to immunotherapies or the checkpoint inhibitor therapies because the tumor cells express these mutant proteins that the immune system recognizes as foreign. So we just got to supercharge the immune system to kill the tumor cells. You've heard about pembrolizumab or Keytruda, which is a checkpoint or PD-1 inhibitor. And actually the FDA in 2017 just approved this for all patients with microsatellite unstable high tumors, regardless of cancer type. And this is kind of a new paradigm for FDA approval of a drug. But again, it happens in 1 to 2% of pancreas cancer patients. And I just wanted to show you a couple of our patients who didn't get MSI tested until they had been treated for a while with chemotherapy. But then they were tested and found to be positive and switched to immunotherapies, which were much less toxic and much more effective. So here's patient number 1, diagnosed in 2016. Stage was locally advanced cancer. You can see the tumor, it's there with the blue line. Patient was treated with multi-agent chemotherapy for 8 months, actually prior to the scan, and wasn't really responding all that much. Wasn't progressing, but not responding, and had some toxicity associated with the treatment. Anyways, because of the toxicity and the lack of response, the patient and oncologist did an MSI testing, which was tested positive. And so the patient was switched from multi-agent chemotherapy to just this PD-1 inhibitor after it was tested. And you can see what happened to the tumor. It shrank from 8 down to 2 centimeters at most. There have been no metastases after a year and a half. Patient's doing extremely well. And I copied this from the oncologist's note, which is unheard of in pancreatic cancer. We'll consider stopping pembrolizumab or treatment at all for this patient after 2 years. Here's patient number 2, which you can see here with the blue lines. That's actually not a pancreas tumor. That's bulky lymph nodes that are around the patient's renal artery and vein that are metastatic from a pancreas tumor. Diagnosed in 2017, was on FOLFIRINOX and Onivide, right? So a 4-drug combination therapy, clinical trial. Not tolerating the treatment well, that's like, 7 months later. Had MSI testing, which was positive. Changed the treatment to pembrolizumab, and again, the tumor melted away again. We're seeing these wonderful, dramatic responses. So, tumor smaller, excellent performance status. So, even though it's only 1 or 2% of patients, I think it's very important to get this testing done because we have a very effective therapy for you if you're MSI high. I wanted to show you our portfolio of clinical trials that we have open at the Agi Hirshberg Center for Pancreatic Diseases. It's a robust and diverse portfolio. A lot of it is with immunotherapy. As Dr. Hecht mentioned earlier, we're also part of the Parker Center for Immunotherapy, and we have a trial open with them that I wanted to tell you about here, which is a immunotherapy that's targeting both the adaptive immune response. So we've got a checkpoint inhibitor, that nivolumab, which helps activate T cells. But we also have this other drug, this CSF1R drug, that targets macrophages, or the innate immune system, which is thought to suppress the adaptive immune system. Anyways, I wanted to show you this patient who's on this trial, right? So this is actually, I think, a MSI low or normal patient who you can see the tumor that's up there in her pelvis. Sorry, I clicked it too fast. There's no, oh, I guess I can go back here. Yeah, up here in her pelvis, really large pelvis. So no microsatellite instability in this patient, 5-centimeter tumor. And patient received chemotherapy for 4 months and then 9 months with multiple different agents. This is a patient, Dr. Hex, of chemotherapy, not really responding. The tumor was getting a little bit bigger. And then we put her on this clinical trial. She's not MSI high, but she was given these dual immunotherapy targeting agents, and she's had a dramatic response to them. We're actually going to start another trial with this double immunotherapy combination for patients soon, and really excited about it. So what's the future hold? You know, we talked about genetic profiling of tumors, some MSI high, the study that showed that those patients who had matched drugs to their tumor profile did better, that we've started developing some KRAS targeted therapies, whether it be T cell therapies or drugs. But I think, you know, what the future holds next, and what many people are working on, and we've developed the infrastructure to be able to do this, is to actually take a patient's tumor after a biopsy or it comes out from the operating room and bring it to the laboratory and either put it in mice to test drugs against it to see if they're effective, which can then be used for you or the patients, or even to do this in a dish with what they call these organoid cultures to see if what drugs could be potentially effective against the tumor. So I think this is what the future holds in terms of personalized medicine. But we've come such a long way from, you know, the 10 years ago that the first sequencing efforts in pancreas cancer got you a paper in Science, to now where it's commonplace and we're actually making it actionable to help patients. So that's the brief overview of personalized medicine and tumor testing. Thank you so much for asking me to speak, and Dr. Hecht and I would be more than happy to answer any questions and try and help you out. Thanks.
Go ahead, question over there, please.
Sure. If a Whipple is done at UCLA, is the tumor tested after pathology gets its work done? And then is that data saved for, you know, children or survivors in the family?
I hope you can hear me, but you probably should address this. But I think what you're asking about...
Does the testing have to be requested, or is that part of the natural pathology work?
Remember, there are two parts of a tumor, there are actually two parts of the genome that we're looking at. One is actually in the patient themselves, which is the predisposition. Actually, Ms. Conlon will be giving, who I work closely with, will be giving a talk about this as well. Then the other question is that when someone has surgery, this is 150-year-old technology, they preserve the tumor. And what they can then do is go back to the tumor to look at mutations that are not in the patient, but are in the tumor. So if tumor is removed, it's always saved, and you can always go back to it. Is that the question? I don't know if I answered that correctly.
How long does that get preserved, or how long is
Forever.
that information preserved? Okay.
Forever. Now, the question is that do we order, normally most patients end up getting something called next gen, which I think Dr. Donahue alluded to, called next generation sequencing, which is kind of the overall of like the Protheron Foundation or Caris or any of those that looks at about 500 different genes that may or may not be important. But you can always go back to the primary tumor. Now, there are other sort of technologies that people are using. For example, the tumor may change over time. So people are using like cell-free DNA, though that's probably not as well, you know, sort of, it's interesting, but there's not as much data for that. but you can always go back. They never throw it away. The only time I've ever had a problem is when someone had I have a patient right now who had a surgery at a hospital that's now closed.
Randy, I can maybe talk, because I know you're sick a little bit, but the question is, try to get your tumor or your loved one. This basically we said, as Dr. Hines and Dr. Donahue said, is germline and somatic mutation analysis.
Yeah, so germline is what's in you, that's in every normal cell, and then somatic is what's in the tumor. So now people can have predispositions, like someone came up and asked me about BRCA mutations, which I unfortunately am very familiar with, and so that's a mutation that's both in the patient, a predisposition, yet is also found in the tumor. Others, like the microsatellite instability that Dr. Donahue talked about, are generally only in the tumor, though there can be predisposition, something called Lynch syndrome for that as well. Did that answer the question? Okay, as long as you can hear me. Any other questions?
Yes, when you were talking about your UC consortium, and all the different organizations that are involved in it. Your table also included a stage 0 category. What's considered a stage 0?
I assume that means like Pan-In or something that was,
I guess so. I'm not entirely sure what the stage 0 is.
I can.
What's a stage
very
1?
many of them up there.
I can tell you, right, yeah.
Stage 1?
The AJCC doesn't have a stage 0 as far as I know, but what is stage 1?
Yeah.
Stage 1 is a small tumor that's confined to the pancreas that doesn't have any lymph node involvement.
Okay, thank you.
Sure.
Hi, I have another question. So I work at UCI, and there's a company that's been having me draw patients' labs. They have to sign, and insurance will pay for it. And they're saying that a tumor can slough off some of these gene mutations and maybe find it through the bloodstream, and then you could target, like what you're talking about. How? I mean, I don't know how accurate is that, because how do you find where it's sloughed? How do you know you got it in the tube? I mean.
So people have been looking at what's sometimes called circulating tumor DNA or cell-free DNA. And people have also looked at, and people confuse this with circulating tumor cells, which are different. And in fact, there are people at UCLA working at trying to get those cells out. But really, you can get much, much smaller amounts of DNA. In fact, I gave a talk yesterday where I showed some slides about this. And you can get just a tiny fraction, because most of the DNA that's circulating in your blood, which comes from dying cells, is normal rather than from the tumor. Now, there are a couple things that it's potentially useful. One is if you don't have any tissue, like that patient, or the tissue's been exhausted or for whatever reason, and so the things that are really common, like you should be able to get a KRAS mutation out of that, because you detect it. Normal cells don't have a KRAS mutation, so you should be able to detect that. And there are a number of things that they're able to look at. They're more and more likely to actually be able to pull MSI. They are not able to look at as many genes. The other thing that's really interesting is that, and this goes back, there was a trial when she was at Hopkins from Donahue, and where they looked, and they're actually, because it takes so long, as was discussed earlier, for pancreatic cancer to get to metastatic disease, that even though they all share the same mutations that were in the original precancer and early cancer, there may be differences. And sometimes treatments, not so much in pancreatic, but some diseases we published, that treatments with a blocker of like one signal to grow, and eventually you lose that. So that's the advantage of that, right? And it kind of averages over all the tumors. So it's interesting. We can get it. The one that we use is called Garden 360, but there are a number of other companies. And so, but I don't think if you have tissue, you should have next generation sequencing on the tissue.
So I should be pushing that for people that don't have tissue.
Yeah.
Okay, thank you.
Annette?
Oh, thank you for such exciting findings. It's also impressive that UCLA has so many trials open. Historically, and for really good scientific reasons, often patients aren't eligible. The eligibility criteria are really strict to get into trials. But I see that some of your trials, you can be on second line, third line, fourth line therapies. What's the outlook for patients being able to get on trials today with pancreatic cancer?
I guess this is me again. And so you're absolutely right. So there's a continuing, as a clinical trialist, because that's part of what I do, there's this tension between wanting to have a defined group of patients so that your answer, what the results that you get make sense. And most importantly, you're the doctor and you want the patient to be on an interesting trial. And what I would say is that actually the oncology community, the feds, everyone else has actually started loosening up things. So for example, there were trials where HIV didn't matter. And so patients with well-controlled HIV, I'm just using that as an example, are able to go on a number of trials. They've actually reduced, this doesn't affect a lot of patients, thank God, but they've reduced the lower limit of age in some trials. But you're right, but when you get to trials, the other thing that's important is that earlier trials tend to accept more people who have. On the other hand, by the time you finally get to a large randomized phase 3 trial, like one of the ones that Tim presented, I'm running a trial with an immunotherapy called AM0010 or peglodekin. Because that's a registrational trial, it's pretty darn strict, unfortunately, for that. That's in second line. But we're getting better, but you're exactly right. There was a patient who came up to me without identifying who said, I have 2 different cancers. How can I get on a trial? And it's like, well, not easily, unfortunately. It makes it harder, but it's gotten easier. Mm-hmm. So.
What?
Hi.
Last question? 2.
1. He's
Just
tough.
1. You're it.
Ready?
Bingo.
Okay, so when it comes to biopsying tumors, say at surgery, so I have experience from my father over the last 2 years. So they did a biopsy at surgery and they did not find a mutation. But when we started chemotherapies for him, we spent a lot of time trying different therapies and none of them worked. So when it comes to biopsies and tumors, are they going to start testing different chemotherapies with the biopsy samples in order to kind of cut down on some of that time? Because we all know that, with pancreatic, time is of the essence.
I would say a couple different things. Dr. Donahue is actually a leader in what are called patient-derived xenografts, so that's not ready for prime time clinically and with models because we want to. We would love not to treat people with drugs that are not going to work. No one wants to do that because you get toxicity with no benefit. Mm-hmm. Instead, what we're trying to do is try to find these biomarkers like we were discussed, like BRCA, where there was just recently within this past week a trial that was presented, or at least press released. We don't know actually the results yet, but it was other than it was positive. The patients whose tumors have specific genetic alteration may benefit. So what I would say, it's kind of a work in progress. On the other hand, most of the benefit that has been seen in pancreatic cancer has been from much better surgery, like Dr. Reber and his colleagues, better chemotherapy, particularly before surgery. I mean, I don't want to denigrate that, but we certainly have a long way to go. But we're kind of on the edge of that.
Okay,
My hope
because
is
I
it
know
will
now
have
it's not a
biomarkers.
standard of care by any means.
I would
because
say
we've
that actually
had
next
to fight
generation,
for
I
it.
would say next generation sequencing has become really the standard of care.
But I mean, testing those things against chemotherapies that might work, it's
Not
definitely
yet,
not a
no.
standard of care right now.
Comment.
Can we take one last question? This gentleman's been waiting.
I'm
This
sorry.
question.
With so many of the new things that we've heard this morning, does UCLA have a protocol of tissue derived from prior surgeries, of periodically reanalyzing those so that the patients that might still benefit from new protocols might be sorted out?
You were talking about like tissue that's been preserved as opposed to
Yep.
new biopsies?
Right.
Okay, so what I would say is that this is actually another tension where sometimes we have trials and we look, for example, like NTRK, where inhibitors are really very helpful, but they're really rare. So you're using an ice pick and you're trying to find that, that sort of that needle. I'm mixing metaphors, but I'm sick. That needle in a haystack. The advantage of the next generation sequencing is that you only find out what you ask. Is that it asks 500 questions, but occasionally it will come up that something that wasn't in that next generation sequencing, we have a specific inhibitor and it's found in a certain percentage of patients, and we will go back, but not routinely unless there's a very specific question.
Great, thank you. Great session. Thanks a lot.